You're back for more. I love it. I want you to know that I Googled misoprostol. It is actually a prostaglandin E. Prostaglandin E is misoprostol.
We'll learn more about it in the, I think, in the abortion lecture.
Yes, yes, yes. Perfect. Okay. Obstetric complications. I first need to disclose that this talk does not do obstetric justice because there's no way that I could tell you all the possible pregnancy complications in 50 minutes. It's just not possible. And even I'm gonna do a cursory job of the 3 that we're gonna talk about. I just picked 3 that I are most common that you're gonna see, but no, you're gonna hit the wards next year, you're gonna come to L&D and you're gonna be like, SDK, this is like drinking from a fire hose all over again and you didn't tell us about this and you didn't tell us about this, so yes, I know. But I picked 3 big ones. I have the same disclosures as previously. Again, I'm gonna do my best to use gender inclusive language. We are gonna talk really briefly about maternal mortality because I do think it's really important. I really wanna acknowledge that you could spend an entire seminar talking about it, so 5 minutes is not adequate, but I think it is important. It would be bad to not talk about it. And wow, you cannot see those words. That is really suboptimal. Okay, well what this says, in case you can't read the white, because I can't read it, is that we're gonna talk about maternal mortality, we're gonna talk about preeclampsia and hypertensive disorders of pregnancy, we're gonna talk about gestational diabetes, and we're gonna talk about growth restriction. So what is important to know about maternal mortality is that actually the postpartum period is the most dangerous for pregnant individuals, specifically within the first 6 weeks postpartum. You can see here that if you think about pregnancy-related deaths, which is defined as death within a year, beginning of conception to the end of pregnancy, it's over half of them are happening in the postpartum period, with about 40% of them happening in the first 6 weeks postpartum. So that is a really dangerous time. During your entire 9 months of pregnancy is only about 30%. This data is a little bit older, but it's not really different. And it looks at maternal mortality in the US by ancestry and by year. For the record, the US ranks last in overall maternal mortality across all ancestry ethnicity among industrialized countries. And again, I could spend a lot of time talking about systemic racism and specifically about non-Hispanic Black maternal mortality. And I wanna recognize it and acknowledge that I don't have time here to really do it justice. This is probably my favorite, but also my most depressing slide, which in not so many words shows that a college-educated Black woman has a higher maternal mortality than a non-high school educated white woman. And I think that is just makes me physically sick. I want to call attention to it. I definitely don't have a solution, but I think it's important to recognize and think about as we care at Duke in Durham for a lot of women of color and being really thoughtful about not only this reality, but also how scary it is for many of our patients to come to the hospital knowing this reality. And so I just wanna put that in context as we go through our discussion today, and I want you to think about it as you come to the wards and you're caring for women who know this reality and are still trusting us with their care. So we're gonna have a little clinic this morning. We're gonna take care of 3 patients specifically. Our first patient is a 17-year-old G1. She's at term, and her intake vitals are just a little bit abnormal with some protein in her urine. The second patient is a 42-year-old, also her first pregnancy that's made it this far. She is 30 weeks pregnant, and last week she failed her glucose tolerance test. Wah, wah. And finally, at 9:10, we have a 34-year-old at 28 and 2 who at her last visit measured size less than dates. We're gonna talk about what that means. And she's coming from ultrasound. Your MA comes and brings you her ultrasound stuff and her baby's only at the 5th percentile. So let's talk about, gosh, I love hypertensive disorders of pregnancy. I will say it's important to know that in obstetrics, we define hypertension differently. We're just not quite with the times. We will get there, and then our worlds will change, but for now, we're still defining hypertension as 140/90. If patients have chronic hypertension, we define that as pre-existing hypertension prior to pregnancy or identified at less than 20 weeks. If you remember the physiology of pregnancy, your blood pressure, a pregnant individual's blood pressure actually goes down from their baseline until about 20 to 24 weeks, and then it starts to go back up. So if someone shows up in your clinic at 12 weeks pregnant and they're hypertensive, they have legit hypertension. In contrast, Things that fall into the gestational hypertensive bucket are when we consider the blood pressure, the elevations in blood pressure to be a consequence of the pregnancy, and then it usually is going to regress postpartum. And we define these as things that occur after 20 weeks. Really, gestational hypertensive disorders come in kind of three flavors. The most mild, excuse me, is gestational hypertension. That is only elevated blood pressures, which I'll define for you in a second. No protein in your urine, no symptoms, your labs are stone cold normal, occurring at 20 weeks or greater. Preeclampsia is elevated blood pressures with something else. That could be protein, it could be symptoms, it could be labs. We're gonna talk about what all those things are, and it can be mild or severe. And then the third flavor is what we call superimposed preeclampsia. So that's a patient who comes to pregnancy with chronic hypertension and gets worsening of their blood pressures, preeclampsia on top of their chronic hypertension. Oh, this does not project well at all. Okay, I'm so sorry. What this says, in words you can't see, is a really nice spectrum with normal. Oh wait, I have a, yes. Oh no, I don't. Okay. Normal being all the way to this side of the slide, and then a kind of a spectrum that goes across the slide with gestational hypertension being less severe than preeclampsia, being less severe than preeclampsia with severe features. Severe preeclampsia or preeclampsia with severe features includes eclampsia, which we're gonna talk about, includes symptoms that make you severe, which we're gonna talk about, includes chronic hypertension with superimposed preeclampsia with severe features, and it includes HELP syndrome, which might be the best acronym in all of OBGYN. We're gonna talk about what that means. So what you're probably gonna say is like, okay, you can get really nasty high blood pressure in pregnancy, but like, why? So it might be related to chronic uteroplacental ischemia. There's some of the hypotheses about that. There's some interesting risk factors related to paternal factors, and so some people hypothesize that actually it's an immune maladaptation. Some people feel like it's some kind of exaggerated maternal inflammatory response to trophoblasts that are places they're not supposed to be. Really, we have no idea what causes preeclampsia. And if any of you are MSTP students and want to figure it out with your career, there is a Nobel Prize waiting for the person who discovers what causes preeclampsia. Because right now, we just have no clue. And I'm really honest with patients when I talk to them about preeclampsia, like, we don't know what causes it. So we can treat the symptoms, but like, how can you treat a disease that you don't know what it is? So currently our treatments really just are for symptoms. There are a lot of risk factors for preeclampsia. This being your first pregnancy, being really old or really young, having any kind of vascular disorder, all increase your risk. Having more placenta, whether that's more than one fetus or a placenta that's abnormally large. There's some interesting data about a new partner. So patients have had like 3 normal term deliveries. They have a new pregnancy with a new partner, and all of a sudden they have really nasty preeclampsia really early. Sometimes we see that. As you have already learned this year, you are always at risk for something you've had before. So a very big risk factor for having preeclampsia is having had it in a prior pregnancy. There's some data that VEGF may be related to preeclampsia through SFLT, and the gene for SFLT is on chromosome 13. So pregnancies complicated by trisomy 13 have more of chromosome 13, so they make more SFLT, they make more VEGF, more preeclampsia. The bottom line is, we have no idea. Oh, this looks so much better. This is what that slide was supposed to look like. So let's talk about the continuum of the gestational hypertensive disorders. Gestational hypertension is sort of the most mild. I hate to use that because it's still scary. We define that as either a systolic blood pressure of 140 or above or a diastolic pressure of 90 or above in someone who doesn't have prior high blood pressure at greater than 20 weeks with no other symptoms. Usually gestational hypertension is pretty mild. It usually resolves. Although the recurrence rate is pretty high here. I mean, almost 50% recurrence, like that's legit. The earlier you develop gestational hypertension within a pregnancy, the more likely it is to progress to preeclampsia or preeclampsia with severe features. preeclampsia is those elevated blood pressures with something else, most commonly proteinuria. I'll also say that when you read the diagnostic criteria for preeclampsia for gestational hypertension, it'll tell you need 2 blood pressures 4 or more hours apart. So that could be on subsequent clinic days, it could be on the same day, 4 hours apart. You can have 2 systolics, you can have 2 diastolics, you could have a systolic and a diastolic, doesn't matter. You need something else though besides just the blood pressures. What we most commonly order on labor and delivery is called a urine protein to creatinine ratio, or a UPC, and if that value is greater than 0.3 or 300, depending on which units the lab is using, that is consistent. That's diagnostic for preeclampsia. You can also use a urine dipstick if you're in a place that doesn't have a UPC. But when you hear us talk about a urine protein to creatinine ratio, we are talking about, or UPC, that's what we're talking about. The other thing I want to make really clear that I think is really important is what's not on here is edema, right? Lower extremity edema, whole body edema is not a diagnostic criteria for any form of gestational hypertensive disorder. Now, let's go back to physiology, right? If you're spilling protein, you have your oncotic pressure is messed up, you're going to seep more fluid. Most of that's gonna become dependent because you have less systemic vascular resistance, and so it's mostly gonna be in your lower extremities. However, every single pregnant patient I've ever cared for in my entire life has lower extremity edema. It is very common in pregnancy. Sometimes it's worse than others, but everyone has decreased systemic vascular resistance, so everyone gets some lower extremity edema, which is why it is not part of the diagnostic criteria. You see it worse in preeclampsia because of the spilling the protein, but it's not part of the diagnostic criteria. Okay, let's talk about preeclampsia with severe features. I think a picture's worth 1,000 words, so I really like this nomogram of the symptoms of preeclampsia, which include a headache that doesn't get better with medicine, blurred vision, scotometer, that's a really good medical word, flashers in your vision, right upper quadrant pain, nausea, vomiting, decrease in urine output, or you could just have really nasty blood pressures. A systolic of greater than 160, a diastolic of greater than 110 will also rule you in for severe features. You can have liver function abnormalities, you can have platelet abnormalities, you can have neurologic symptoms we talked about, you can have creatinine or kidney failure. You can spill fluid into your lungs, like pulmonary edema, and you can seize. You don't necessarily need to have proteinuria to have preeclampsia with severe features if you have some of these other severe features. This is a complex disease, and again, when you don't understand the pathophysiology of something, you're just describing it based on symptoms. But essentially, the way that I think it's helpful to conceptualize it and the way I talk about it with my patients is there's something in your body, we don't know what it is, that is irritating all of the vascular beds, right? It's irritating the vascular bed in your brain, you can get a headache, you can get seizures, you can get vision changes. It's irritating the vascular beds in your general blood pressures, making your blood pressure go up. The vascular beds in your kidneys, you're spilling protein, you can go into renal failure. You can imagine how all of these different things, different vascular beds are being affected by whatever is causing the preeclampsia. Yes, yeah?
Just for clarification, for preeclampsia not with severe features,
Yes.
do you have to have proteinuria?
Yes. Because if you only have blood pressures without proteinuria, you have gestational hypertension, and if you have any of these, you qualify for severe features. Another manifestation of preeclampsia with severe features is called HELLP syndrome, hemolysis, elevated liver enzymes, and low platelets. You could imagine, like, this is really bad. These patients get really sick. It's really scary. A lot of patients will have like a little bit of this. They'll bump their LFTs or their platelets will drop a little bit, but they won't have the whole spectrum of things. But this can get really severe. You know, it's not uncommon that we have patients with platelets less than 50, with LFTs in the multiple hundreds. These patients, again, get really, really sick. Now, I want to talk about eclampsia because I think there's a lot of misnomers. The first thing that's really important is that pre-eclampsia does not really precede eclampsia, and that the vast majority of patients with preeclampsia do not seize. Also, many patients who seize have no history of high blood pressure and have no preceding pre-eclampsia symptoms, which is actually really scary. In the bigger studies in general, about 40% of patients who have an eclamptic seizure have no preceding documented history of hypertension or proteinuria at all. And many women who seize actually have just mildly elevated pressures, but don't actually have super nasty, scary, severe range pressures. Sometimes it's preceded by a bad headache, by vision changes, but eclampsia is really nasty. And in the pregnant patients that we care for, patients who have a new onset tonic-clonic or focal or multifocal seizures, we assume it's preeclampsia until we can rule something else in. So the vast majority of pregnant individuals without a history of epilepsy who have a seizure, it's gonna be related to preeclampsia and not a new random brain tumor or a new onset epilepsy. Okay. Before we dive into the evaluation and workup, that kind of goes through the spectrum from gestational hypertension, preeclampsia, and severe preeclampsia. Any questions about that? Okay, great. I know your brains are really fried from the other lecture, but it's okay. This is important too. So when patients come in for rule out preeclampsia, we want to talk to them about their symptoms. Any headache, any blurred vision, any pain in your upper abdomen, any nausea, any vomiting. We also want to look at their vital signs. One of my most memorable moments in med school is when I forgot to ask them vital signs on my surgery oral exam, and the surgery clerkship director said, "Sarah, they're called vital signs because they're vital." Still with me. I can't tell you his name, but I can tell you that he said that to me. So they're vital. They're really important. What are her blood pressure? And then we're going to get labs. And the routine labs we get on any patient where we're ruling out preeclampsia is LFTs, CBC, and basic metabolic panel, which is going to include your creatinine. And then we're going to get a UPC. Sometimes we'll get a uric acid as well. So, okay, you've told us we don't understand what causes this disease, that it can make patients super duper sick. How do we cure it if we don't know what causes it? The good news is we got really lucky a long time ago, and somebody figured out that if you take out the placenta, patients get better. So the only thing we know about how to cure preeclampsia right now is to deliver the baby. Now, for a patient who's term, that's easy. Over 37 weeks, if they have preeclampsia or if they have gestational hypertension, they're term. Like, that baby is cooked. We can deliver that kid. When you think about the risk benefit of a preterm birth for the fetus versus the maternal risks, as long as there's no severe features, we can expectantly manage a patient who has only gestational hypertension or only preeclampsia until 37 weeks when that balance shifts, and then we deliver them. But if they have severe disease, they are sicker and the risks are much higher. So patients who have preeclampsia with severe features, anywhere past 34 weeks, we deliver you. Now, if you're less than 34 weeks and you develop preeclampsia with severe features, then it becomes a little bit of walking a very narrow fence to figure out how do we optimize the time in utero for the fetus, but also keep our patients safe. The first thing we always do is give patients with severe features 24 hours of magnesium sulfate. That's going to decrease their seizure risk. If they're severe because they're having super high blood pressures, we also give them medicines acutely to bring their blood pressures down. And if their body responds to those medicines and their pressures are not severe, they can stay pregnant until 34 weeks. If they have other severe features, they're not peeing, they have pulmonary edema, their platelets are 50. It doesn't matter their gestational age, the risks to the pregnant individual are so much higher that we recommend delivery at that point. We don't let that person stay pregnant. I will say preeclampsia is one of the most scary conditions that I manage. These pregnant patients can get really, really sick. It's one of the leading causes of maternal mortality across the world. I have seen a lot of very, very sick patients with this disease. They end up in the ICU, they end up with a hysterectomy. They get really sick and it's really scary. So we take preeclampsia really, really seriously. And it's also bad for the kiddo, right? The placenta is a vascular bed. So while growth restriction isn't really a severe feature, like the fetus is not so happy in there either. We watch those patients in the hospital, we watch their baby every day just to make sure the baby is okay. IUFD, again, stands for intrauterine fetal demise. And so these patients can get really sick and babies can die. So again, preeclampsia is bad. Take-home message. Someone before asked about prevention of preterm birth. For the prevention of preeclampsia in patients who are high risk, which is anyone who had that list of risk factors that I showed on an earlier slide, we recommend a low-dose aspirin starting at 12 to 16 weeks. They did a really nice randomized control trial, multi-center, aspirin, no aspirin, and the aspirin group had less recurrent preeclampsia. So if you've had preeclampsia before, or if you're high risk for preeclampsia based on any of those risk factors we talked about, you're gonna be on a baby aspirin. All of preeclampsia in, that's right. Oh, 25 minutes, okay, that was not enough time. That was too much time on preeclampsia. Questions about preeclampsia? No, yes.
If someone had preeclampsia and ended up having to deliver before 30 weeks or the outcome of the pregnancy was not good, would you ever recommend them not to get pregnant again?
Yeah, it's a really good question. It takes a lot for us to say, don't get pregnant again. Even patients who get really early severe preeclampsia, we counsel them about the recurrence risk, which is high, but I don't know that I've had a patient where I said, don't get pregnant again. Now, I could think of a patient who had really bad help, required a liver transplant, came back and wanted to do preconception counseling, now status post liver transplant, and I would feel really nervous about it, but I don't know that I would say don't get pregnant. There's very few conditions where we say actually don't get pregnant. But I think I would very strongly counsel them the risk of the same thing happening again and having another really catastrophic outcome for you and or your fetus would be really high. It is always safer to not be pregnant than to be pregnant, right? Even if you are a low-risk, healthy person, it's always safest to not be pregnant. Pregnancy is dangerous. So I don't think I would counsel them not to get pregnant, but I would definitely, watch them closely. For any patients who had preeclampsia before, we get them a home blood pressure cuff, so they're monitoring pressures at home as well. And then the other thing that's not really in these slides, but that's important to know, is that patients who have had preeclampsia are at increased risk of cardiovascular events later on in life, at increased risk for chronic hypertension, MI, cardiovascular badness. And so those of you who do not go into OB, but care for patients who have been pregnant later on in life, knowing their pregnancy history may inform your risk reduction strategies when they're older. Okay, you ready to talk about growth restriction? Love IUGR. I will say that you'll see in textbooks, you'll see us use IUGR or intrauterine growth restriction interchangeably with FGR, fetal growth restriction. They mean the same thing. I think it's important just to do a quick terminology, which is we talk about growth restriction on the inside and LGA or SGA on the outside. So a baby, a neonate after it's born, is LGA, large for gestational age, or SGA, small for gestational age. When we have kids on the inside, we describe them as IUGR. The other thing that I always talk to patients about that is so important is there is a lot of variation in how much a baby can weigh. And a lot of different reasons that babies grow the way they do in a totally normal circumstances. If you took 100 people, all of whom have your own birthday, everyone's gonna be a different size. And 10 of them are gonna be the smallest, and 10 of them are gonna be the biggest, but that doesn't mean there's anything wrong with those people, it's just how they are. So it's challenging to think about accelerated growth or growth restriction because we're all different. And I think that's important to think about. I love this picture, which is a small for gestational age infant next to an LGA infant, and you can really see they look different even though they have the same gestational age. A picture's worth 1,000 words. When we think about growth restriction, we really think of that to be anything less than the 10th percentile. So again, if you lined up 100 fetuses all with the same due date, number 1 through 9, we would consider growth restricted. What's really important, and I tell this to patients all the time, is that 70% of those, that's just their genetics. That's just who they are. And it's not even because mom and dad are small humans. Sometimes 2 giant people get together and the way their genes form, it just makes a small human. And sometimes 2 small humans get together and makes a giant human. It's just constitutional. But 30% of those kiddos are actually at a higher risk for various reasons. And those are the ones we need to watch out for. And it's really hard to figure that out on the inside. You can see growth restriction for a lot of different reasons. The most common being placental insufficiency. So the placenta just isn't as robust as it could be, either related to maternal disease, to recreational drug use, maternal choices. Sometimes poor weight gain can do it in patients who are really underweight or really overweight, really young, really old. All of those things can affect how the placenta works. There's so much about the placenta we don't understand. Sometimes it's like a healthy, normal person doesn't have any of those, but the placenta just didn't form right. And so those are patients where baby's really small, the placenta's not working well, and we don't have a clear external reason that makes sense for that. Sometimes it's related to an infection. You're gonna learn about the TORCH infections if you haven't already. The take-home thing you should know about TORCH, toxoplasmosis, other rubella, CMV, and HSV, HIV, is that really CMV is the bad player here. Congenital CMV infects about 1% to 2% of pregnancies. We don't have a good screening tool, and we don't have treatment. So this is like a really nasty disease that's really prevalent that we just aren't good at treating and aren't good at finding. And it's the most common infection that causes growth restriction. These other ones are really uncommon. We do have a rise of congenital syphilis. We occasionally will see parvo, but most commonly, if you're worried about a congenital infection with a small kiddo, CMV is what I want you to think about. Some genetic syndromes can lead to growth restriction, including the common aneuploidies, with T13 usually being the most severe of these, but honestly, trisomy 21 and 18 also cause growth restriction. And sometimes there just isn't a lot of space. There's a big argument, should twins have different growth curves than singletons? Because there's just not a lot of space. My favorite twin fact, right? At 25 weeks, a twin uterus is the same size as a 40-week singleton uterus. Those babies still have 15 more weeks to grow, but there's not enough space because it's already a 40-week size. So, sometimes there's two babies, there's just less space. So we talked about what is fetal growth restriction. We talked about what are the risk factors or things we see associated with it. How do we diagnose it? Remember that for all patients, right, when we can, we like to measure a fundal height, which is the distance in centimeters from the top of the pubic symphysis to the umbilicus. What's super cool is that at 20 weeks, that distance is usually 20 centimeters. And then every week, the fundus is gonna grow a centimeter. So you can estimate a patient's gestational age just by measuring right here. You don't need an ultrasound. If you get to be obstetrically savvy enough, you know the distances apart with your fingers, you can just measure with your fingers. I know this is 3 centimeters. This is 5 centimeters because I've measured enough cervixes. You have to be really obstetrically savvy. I know when you start to measure things in centimeters with your fingers, you've been an OBGYN for too long. But this is cool, and it's amazing how the body works. And it's a really nice way to estimate how pregnant someone is and to estimate how babies are growing. That's very low tech. Now, if you have twins, it's not gonna work. If your patient has giant fibroids, which are benign uterine tumors, it's not gonna work because they're gonna make the uterus big. If your patient's BMI is 60, it's not gonna be accurate because you're gonna have, PANIS here that's gonna impact your measurement. But this is a great clinical screening tool, and when your fundal height is 3 or more centimeters different from your gestational age, you should get an ultrasound. Because those are the patients that are at highest risk for growth aberrations, whether it's 3 too big or 3 too small. And then when you get that ultrasound, you're gonna look for either an overall estimated fetal weight at less than the 10th percentile or an abdominal circumference at less than the 10th percentile. And you're gonna say, SDK, why are we using a belly measurement? That doesn't make sense. Like, what if this kid just has a big brain? I know, it's a really good question. But just like us, right? If we stop eating, where do our calories come from first? Right here. If the placenta's not working as well and the baby's not getting enough nutrients, the first place that's gonna fall off is the abdominal circumference. The baby's smart, it's gonna spare its brain. The calories go into the brain, but not the belly. So a small AC being abdominal circumference, is also really worrisome. When you find a fetus that's growth restricted, we follow growth every 3 weeks to make sure that that baby is continuing to grow. We also offer non-stress tests. So we put the baby on the monitor and we listen to make sure there's no concerning findings in the fetal heart rate. We also do something called a biophysical profile, which is just another way to assess the baby with an ultrasound. Is it wiggling? Is it moving? Is it kicking? Does it have adequate amniotic fluid? Is it practicing breathing? And we look at the blood flow through the umbilical cord. So, God, I love amniotic fluid. I'm such an OB nerd. You can measure the amniotic fluid volume or the amniotic fluid index with ultrasound. A normal volume of amniotic fluid is between 5 and 25 centimeters. And we measure that by measuring vertical pockets in all 4 quadrants of the maternal abdomen. This is an example of what that might look like on ultrasound. There's 4, you can sort of see the depth in all 4 quadrants. Now, are you ready for this? This is so cool. Amniotic fluid is baby pee, right? When you are on the outside, and your body goes into shock because, well, let me make it clear. You've been standing all day long, you've been sitting in class, you haven't been eating, you haven't been drinking. What is the first thing that your body's gonna stop doing? It's gonna stop making urine, right? You're gonna produce some ADH, you're gonna hold on to your fluids because you don't have enough fluids. Your body goes into shock because you're hemorrhaging. What's the first vital sign that's gonna change? Your urine output, right? ADH, renin-aldosterone system, it's all in there, right? You're gonna hold on to your fluids. The fetus is the same way. If the baby is getting really stressed out, it is gonna start holding on to fluids, which means its urine output is gonna go down, which means its AFI is gonna go down and you're gonna see oligohydramnios. So oligohydramnios is really scary because it's decreased fetal urine output. That kid is stressed. God, it's so cool. Just wait till we get to GDM. Okay. This is an example of a very IUGR, a little IUGR, and a normal kiddo at term. You can see, again, they look really different. The amount of brown fat is super different. Again, you don't really need to know the specifics of delivery timing, but the more concerning the antenatal testing is, the earlier we deliver it, or the smaller the kiddo is, the earlier we deliver. Immediately, I'm doing really good on time. Fetuses who deliver in the neonatal period have increased risks related to their growth restriction. They have a hard time maintaining their temperature. They have a hard time keeping their sugar up. And then even kind of longer out, they have higher mortality in general. They have increased difficulties transitioning to extrauterine life. In childhood, they tend to be a little bit smaller, they have a higher risk of some neurodevelopmental outcomes, and in adulthood, they have higher risk of ischemic heart disease. So there are some fetal programming things that happen to these kiddos that are born with IUGR that really impact them for their whole life. Okay, questions about growth restriction or aberrant fetal growth? So cool the way the body works. Your brains are tired. I know, this is a lot. This is a lot of things in 2 hours. The last thing for us to talk about is gestational diabetes. Okay, deep breath. This is the last thing. We're getting there. You're so close. So GDM is gestational diabetes, just that, diabetes diagnosed in pregnancy. One thing that can be challenging, both about sort of the chronic hypertension as well as diabetes in pregnancy, is that a lot of young, healthy individuals in their 20s and 30s don't regularly seek healthcare because they don't need it. It's expensive, it takes time away from work. Like, I don't know, there was a long period where the only provider I saw was my obstetrician, and I'm in healthcare. We won't call it any of you to ask you how long it's been since you saw your PCP, but like, if you're young and healthy, you don't really need a doctor. And so a lot of patients will come to pregnancy without any underlying diagnosis, but having not seen a provider in 10 years, 12 years, because why bother? If you're healthy, you feel good, you don't need it. So we call diabetes diagnosed in pregnancy GDM. That being said, if your first trimester A1C is above 6.3, we say like at less than 10 weeks, that's real GDM, that's real diabetes. But in general, if you diagnose it in pregnancy, we call it GDM, even if it was probably pre-existing. It's also important to know that patients who come to pregnancy with pre-existing diabetes cannot get like superimposed GDM in the way that you can get like superimposed preeclampsia. If you come and you already have type 1 or type 2, like we don't screen you, we don't test you for diabetes, like you already have the disease. We're gonna work on controlling it with you, but we don't have to do any of this GDM screening stuff. The placenta, once again, so cool. Makes a lot of hormones, but the most sinister one from the GDM perspective is called human placental lactogen. This is an important hormone, you need it, but it works against the placenta and increases insulin resistance. Now, that's pretty good because we need some sugar to cross the placenta and go to the fetus. So it is physiologic, but in a patient who has baseline insulin resistance or who's predisposed to insulin resistance genetically, they are at higher risk of GDM because of the HPL. I always tell patients, it's not you, it's your placenta. No, nothing? Come on. Okay, so again, risk factors for gestational diabetes, having had it before, having had a giant baby before, using glucocorticoids. We know that glucocorticoids increase your blood glucoses. A family history of any kind of diabetes, obesity and PCOS, most likely because PCOS is most commonly linked with some kind of metabolic syndrome, which most commonly also has some baseline insulin resistance. So how do we screen for GDM? In order to screen for GDM, we do a 50-gram glucose load. It is nasty. It tastes like flat Fanta. They also have it in fruit punch, lemon, lime. It doesn't really matter. It doesn't taste good. It is like drinking syrupy sugar. Sometimes we call it glucola. Sometimes we call it the glucose challenge test. Some people call it the O'Sullivan test. All of those are a 50-gram glucose load. You do not need to be fasting for your screening test. I think that's really important. A lot of people are worried about that. You do need to be fasting for the diagnostic test. With the screening test, if your value at 1 hour, your serum glucose, it's not a finger stick, is greater than 140, that is a positive screening test. And then you have the opportunity to do the glucose tolerance test, which is a fasting 3-hour, 100-gram glucose load where we check your blood sugar fasting at 1 hour, 2 hours, and 3 hours. And if 2 or more of those values are elevated, then you receive the diagnosis of GDM. Every patient who does not have a pre-existing diagnosis of diabetes gets screened at 24 to 28 weeks. If you have these risk factors that you see on this slide, you get to do it twice. Once early on in the first trimester at 12 to 13 weeks when you come for your new visit, and if you pass, again at 24 to 28 weeks. What really is the worst is if you fail your screening test early on, you have to do the 3-hour GTT, but you pass it, you have to repeat the 3-hour test at 24 to 28 weeks, which just sucks. I mean, who has 4 hours to go and sit in a clinic and not eat when you're that pregnant? Like, it's just cruel what we do to our pregnant patients. But GDM is bad, so we have to screen and test for it. About 15% of patients in a low-risk clinic will have an abnormal glucose challenge test. Of those, about 15% will go on to develop gestational diabetes. Now, why do we care about GDM? It is not awesome. It increases your risk of preeclampsia. You are more likely to have a larger fetus, which increases the risk of either shoulder dystocia, which is where the head delivers, but the shoulders get stuck in the bony pelvis, as well as cesarean delivery. We're gonna talk about polyhydramnios, and interestingly, we love to think of pregnancy as a window to your future life. But diabetes is definitely one of those where when you have GDM, your risk of developing type 2 diabetes in the next 10 to 20 years is actually really high. You can see those numbers. It's also not awesome for the fetus or the neonate. So again, a bigger fetus, gestational diabetes increases your risk of a bigger neonate. Macrosomia implies over 4,000 grams, which is almost 9 pounds. Interestingly, neonates born to moms or to birthing patients with gestational diabetes are at higher risk for hypoglycemia. which also kind of confuses people. But if you think about it, what's kind of interesting is that pancreas, the fetal pancreas, has been on overdrive managing all of the maternal glucose load. Then it comes out, is out of the sugar syrup, doing its own thing, and the pancreas is like, insulin, insulin, insulin. And then the unit's like, oh God, and the glucose goes, whoop. So all infants born to any mom with gestational diabetes, but specifically those, or type 2 or type 1, gets blood sugar checks because of that risk of hypoglycemia. And then in our offspring born to moms with, or birthing parents with gestational diabetes, there's an increased risk of childhood obesity, higher rates of inattention, their lifetime risk of diabetes, so of the risk of the neonate when it gets older is also much higher. And then we talked about increased risk in a pregnant person to have diabetes as their life progresses. Okay. When we think about GDM, we have to treat it because hyperglycemia is bad for the fetus, as you saw, bad for the neonate, and bad for the pregnant patient. So the first thing we do is just some diet and exercise counseling. Many of these patients have never had a diabetes diagnosis before, so they all meet with a nutrition consultant or and go over like, what is a diabetic diet? What is appropriate portions? What are carbs? Kind of that basic diabetes counseling that we all know because we've learned it in our med school, but that for a lot of patients is not second nature. We also have them check their sugars for a week. Now, interesting and different in our gestational diabetics from our pre-existing diabetics, we have them check a fasting, and then we have them check 2 hours after they eat. You're gonna be like, what? Why would you check after you eat? That doesn't make any sense. You're right, except the postprandial glucose values is what the fetus is seeing. So that gives us a sense of the degree of hyperglycemia that the fetus is exposed to. And as you know, those of you who have kind of like nerded out about diabetes before, these are pretty tight values. Most patients who have pre-existing diabetes, we are not this tight with our glucose control, but a fasting less than 95 is pretty low, and a 2-hour postprandial less than 120 is also pretty low. I will add here that it's important to know that you can also check 1 hour. So for some patients, like if you have a 1 hour lunch break, you need to check 1 hour. As long as it's less than 140 at 1 hour, that's also okay. There's no data that 1 hour versus 2 hour postprandials are better or worse, just the normative value is a little bit different. If more than 30% of any value is elevated from a blood glucose perspective, then we recommend adding medication, and usually we start with insulin. We also watch how these fetuses grow. Again, in contrast to the FGR fetus, fetuses in gestating within pregnant individuals with GDM, when you have extra sugar, right? If you eat candy bars for lunch every day, it goes to our abdomens. So the first thing we actually see to be larger in a fetus gestating in a patient with GDM is a big AC, or a big abdominal circumference, because it all goes to the abdomen. Additionally, when there's extra glucose, you have glucose in your urine, you have glycosuria. Many patients with diabetes have polyuria. So what do you think the amniotic fluid of a fetus gestating in a patient with GDM looks like if the GDM is not well controlled? Yeah, they have polyhydramnios. They have too much extra fluid because they have polyuria, right? They are peeing out the extra glucose. It's so cool, polyuria, I know. You never thought someone would nerd out about baby pee, or fetus pee, really. So we follow the fetus's growth because that's a sense of how the glycemic control is affecting the baby. One of the most challenging things about GDM is that sometimes patients will have really good glycemic control. They'll bring their blood glucose logs, they're all really normal, but they have an ultrasound and their baby's giant, which just goes to show that like sometimes, even though the glycemic control is really good and you can't do anything to improve it, the way that the fetal programming is happening is still growing a really large human. And sometimes like that's just how it is. For patients on medications, we also do non-stress tests and amniotic fluid index. And then depending on how the baby's growing, what their sugar levels look like, that helps time our control. We know that in labor, tighter glucose control decreases the risk of neonatal hypoglycemia in the neonatal period. So for patients with GDM and also type 1 and type 2, they often need an insulin drip in labor to ensure tight glucose control. What's super slick about GDM is that because it's not them, it's their placenta, when you take out that placenta, guess what? They're cured. They stop all of their medicines after the placenta comes out. They don't need any insulin. Even patients on hundreds, I won't say hundreds, but on high doses of insulin for GDM, you deliver that placenta and boom, bye-bye HPL, bye-bye placenta, bye-bye GDM. We still do check a fasting blood glucose on postpartum day 1 to make sure that this wasn't some kind of pre-existing diabetes that we just missed because the patient didn't access care. I will say that between when a baby is born and postpartum day 1, usually the pregnant individual is not fasting because they are getting up every 2 to 3 hours to nurse their baby or to bottle feed their baby, whatever their preference is, and they're probably having a snack during that time. So making sure when you're checking a fasting on postpartum day 1 that actually the patient has not eaten for 6 hours. It's really unlikely. But we do that just to be sure there's no that it isn't pre-existing type 2 that we just sort of found in pregnancy. And then the gold standard would be to give the patient a 75-gram glucose challenge 6 weeks postpartum or after breastfeeding to really ensure that the GDM is cured and that this wasn't kind of just pre-existing disease. Whoa. 4 minutes to spare. That was amazing. Okay, questions? Yes.
So for the kiddos that are delivered and the mother or the woman who gave them or birthed them has GDM, how long does it take typically for that hypoglycemic state to normalize?
Yeah, it's a good question. It depends a lot on how well the GDM was controlled or the diabetes was controlled. So some babies actually end up, I delivered a baby on last Friday, I think, who got delivered early last Saturday night, that got delivered early for like a GDM, and the sugars were okay. The baby wasn't giant, but the antenatal testing was really non-reassuring. And that baby did okay in the delivery room, and then they checked, it was like kind of jittery. They checked its sugar like in the delivery room, and it was undetectable. So that baby went to the neonatal ICU for blood sugar monitoring. If the sugars are all normal, I think they check them for 24 to 36 hours. And I don't want to give you the wrong number, but the frequency is Q4 to Q6, I think, as maybe a little bit closer together right after baby's born. Don't write that down, but usually about a day to 2 days, they're following the sugars if they're normal. If they're low, it's different and there's a whole protocol for it. Yeah. I'm coming to you next.
You talked a little bit about for individuals who are pregnant that have hyperglycemia, the neonates are at risk of hypoglycemia
Yes.
because it like taking away all that glucose. Is there any risk of the opposite in individuals who are pregnant that are on insulin? Like, is there any risk of the neonates
It's
not producing enough of their own
Insulin does not cross the placenta. So we don't see fetal hypoglycemia. It's a really good question. Yes, over here.
Going back to the screening for GDM, if a patient were to fail the GCT but then have a normal GTT, would we do any management or monitoring?
Yeah, it's a really good question. There's lots and lots of studies about this. Other than a slightly increased risk for a slightly bigger baby, there isn't really good data that any kind of intervention changes the outcome. So some places will offer those patients nutrition counseling because probably there's some degree of insulin resistance there, not enough to like tip them over into GDM. So there are places that will offer counseling for those patients, like nutrition counseling, but there isn't really any intervention for those patients because they passed their diagnostic test. Yeah, it's a really good question. Okay, you're ready for L&D next year. Other questions? Okay, awesome. Thank you for coming. I know that this is not required, so thank you for showing up and asking such thoughtful questions.